Now, our Canadian TCPS guidelines talk about a proportionate approach. In your proportionality is a principle. It means don't put the most awful case scenario, you know, the worst risks that can happen, the what if one day somewhere, somehow, someone does something as your standard, because nothing will get through. Actually, balance, are there real risks, not just hypothetical risks? Taking a proportionate approach in your evaluation of whether the privacy and security safeguards match up to the ethical standards in your country. So this is different. You can have expedited review for a lot of minimal risk research. Accountability, which is going to be up, as I said, in a week on the web for a month for comment. This is interesting because it has 5 stakeholders: journals, see if I can remember them all, companies, funders, researchers themselves, and advocacy groups, and so on, all under this accountability policy. A new feature, and without, of course, the Alliance has no sanctions. We have no power, we have no money, we don't even give money, we don't have any, we don't control anything. But we want to provide the mechanisms that researchers, funders, and so on can use to hold the research community accountable. But the new thing is, why are you not sharing your data? In other words, if you have consented data and you're sitting on it, why are you not making it available? You are accountable to the public who participated and to the funders who allowed you to do your research. So again, this is a new twist under the Global Alliance. New projects coming out. This is the Pediatric task team. Each working group, I should explain, has task teams. It's sort of like communist cells. You have an idea, you find colleagues around the world that want to work on an idea, you talk to the clinical working group or the data group or the regulatory ethics working group, you say, I have an idea, this is an issue, I need to discuss it, we've got to do something about it, create a task team. This is our pediatric task team. And before it gets to general pediatric issues, the chairs of this task team, one of whom is a Canadian, Jan Friedman from British Columbia, say, what's the most urgent issue before you start doing more prospective stuff? They said, oh, we really think newborn screening programs are going to be challenged in a way they've never seen before by people wanting to do whole genome sequencing at birth. And they're going to try slip it in under a newborn screening program, which is meant for children with metabolic conditions that need to be treated right away, and destroy what actually is a program in the best interest of the asymptomatic, unfound, untreated newborn. And so coming out, it's been sent out for publication on policy considerations and recommendations, how to keep our newborn screening programs in the best interest of the child, and at the same time recognize that whole genome screening is being used clinically right now for newborns where the physicians do not know what these babies have. These babies are very sick or they're dying, and newborn screening is now in the NCU, in the intensive care, is the diagnosis method of choice for such children. And I think that is a different issue from taking a whole state-run, state-paid-for newborn screening program. So here are some of the initiatives. Machine-readable consent, which I don't understand, but it's moving along with all the geeks and it's really amazing to see the language that they talk is something else. The one that has my immediate attention is the ethics review equivalency. Whether we do it in Canada, maybe we should start here. We could show the world it can be done, particularly Europe. We're thinking internationally and we're thinking Canadian, and their CAN share that was just mentioned. How do we get, let's say, 17 researchers across Canada from different institutions go through 17 ethics committees? I did it once in a 3-year project. I did 18 ethics committees. It took a year and a half of a 3-year. We only had 18 months or whatever, 17, to do the science. Waste of money. I don't know what happened to the science. Hopefully science is all right. But I mean, that made no sense to me. So if it makes no sense in one project, that was just in Quebec, try doing it across Canada. We want to do what I would call a controlled light. It's registered, you have to register. An ORCID ID is not sufficient. Enough so it's all going to be online if we work it out. To authenticate you, we need to have you attest that you will follow certain conditions or meet certain conditions, and if so, you will be authorized. And this is for a minimum risk research. So finally, 3 demonstration projects. What are 3 projects that are being led by Global Alliance researchers, and what do they want to do? Okay, the first and the most challenging is the BRCA challenge. Now, we all know about Myriad's patents and the long story and everything else about Myriad, so I won't go there. But they still have the best database in the world. There's no doubt about it. You want the best diagnosis, you send your samples there. What we want to do is create a database, international database, of equal, if not better quality, and make it accessible to researchers around the world. Now, this won't be a diagnostic database because, boy, even as a lawyer, I couldn't dream of how to handle a diagnostic database internationally. But it will have 3 categories. So if you have someone in front of you who has who you think is going to be tested for BRCA or whatever, it'll say benign, variant of unknown significance, or pathogenic. In other words, the clinicians who use this database can at least decide what road to start on. Okay, benign, unknown significance, or pathogenic. So it's not a clinical diagnosis. You still need to go to a really good lab and do all that other kind of stuff, but it will allow for more efficient initial categorization of patients. Now, this is complicated, as you can imagine, because we already have databases. Now, I've just taken these 3, but there's a lot more. LOVD is in the Netherlands, by the way. NCBI is US, and UMD is in France. And we looked at the overlap. In other words, everybody's building their little kingdoms, and drawing up the ladders, and the moat is around it. Whereas what we want to do is combine not centralized, via a single portal, access to these federated databases that are curated and annotated together. So you have one entry point, but you have access to all the data from these 3 and many more that are joining the BRCA Challenge, which, by the way, has piqued the interest of UNESCO as well, and is a sponsor of this, in kind, so to speak. So we want to bring all this in and curate it and the rest of it. Oops, but there's an issue with, I have to go back. There's an issue with this. Esperanto doesn't exist. We need to have some common or concordant, doesn't have to be the same, but concordant. I'll give you an example. De-identification. Okay. To me, I say HIPAA. That's the United States. Oh no, de-identification in HIPAA means 18 variables that are taken off: address, social security number, name, date of birth, and so on. But de-identification is used as a verb, meaning a process to de-identify data. Then you get the Europeans with their new regulation, I can never say it, synonymized data, pseudo-anonymized data. And by that they mean coded, as we call it here. It isn't the same as de-identified data in the United States. And I can go on and on and on. So we need to know if the terms mean the same thing, let's at least say that they mean the same thing and understand each other, because coded data is very different from anonymized. Anonymized means irreversibly delinked. Need more sources. And of course, my team is looking at potential liability. You're a clinician. You say benign. 3 months later, if you don't go back to the database, what if that variant has suddenly become pathogenic? Or what if you say unknown significance and 3 months later it's become significant, either one way or the other? So we have to look at how to send out alerts and that kind of thing as well. And single portal, and what kind of oversight, both of the science of the database and of the people who access it. So, in conclusion then, we've been working for 2 years at the Public Population Project Genomics and Society and with my research chair. and until 8:30 this morning, no money to build these tools in a hopeful, prospective way. I can't emphasize how happy I am that CFI has gotten into cyber bioinformatics and data and so on as an infrastructure science. We do, however, need infrastructure policy, and I'll tell you why. We get the same requests, even if you are an LC, ethical, legal, social issues, or GELS as we call them in Canada, embedded person in a research project. And thank you that Genome Canada and CIHR have realized the importance of ethics in their research. That's not the same as having common tools available that don't have to, policy tools, that don't have to be reinvented for every researcher. They all need IP policy. They all need publications policy. They all need consent templates. They all need privacy and security policy. I can go on. And it's always, of course, you have to customize them according to the science, because everything is different. But there's this need for policy infrastructure. So we've created this Policy Interoperability and Data Access Clearinghouse in P3G, which is a not-for-profit international consortium. And right now we're working with the International Cancer Genome Consortium. We're also working with the International Genome Sample Resource in the UK. We're working with Autism Speaks for international, and so on, doing the tools for these consortia. But it's on a piecemeal, project-by-project basis. So we've created a one-stop service, and we've done the clauses, as you see there in the third one, for the Global Alliance. But for 4 or 5 European projects, when they get together, they need to know if they can work together. Are they incompatible? What do they need to do to make sure that these 9 biobanks can actually share? We have created a DACO, a Data Access Committee, with informaticians, sociologists, epidemiologists, lawyers, bioethicists. So we do all the data access for 3 or 4 of these large international consortia, because we're independent. And finally, we've created a new entity called Data Trust, which is to support, as we move to the clinic from the science, to support the imbroglios that come, what do you do with whole genome sequencing when you see so many results? Some that you understand, some that you don't understand, and some that have meaning only in the future. Who decides when to communicate that data? To whom? What did you promise? Even more to the point, what do patients expect? And I can tell you now, no matter how you want to protect pediatric children and this and that, they want everything. And they don't care if you understand it or not, or your paper hasn't come out or whatever. They say, give it to me. And you can expect more and more of this. And they said, we'll figure it out, and if you don't know it, we understand you don't know what it means. And yet you say, yeah, but if I give it to you, then 10 years from now, if we're not in contact and you get something, you'll say, but you had it 10 years ago. How do we responsibilize, I know that's not English, patients, empower them, and at the same time not be like, what do you call those clauses? Disclaimer clauses in every physician-patient relationship. So we need to work on mechanisms for this. And then at 8:30 this morning, 1 hour ago, this is a project that actually was approved in April, but due to elections and everything else. So it was announced this morning, thank you, Genome Canada, Genome Quebec, Genome BC, Genome Ontario, and CIHR. This is a project where Canada, in a very small way, is supporting Canadian researchers on the right. You can see Matchmaker Exchange, those are Canadian researchers, Beacon, Canadian-led, BRCA Challenge, Canadian-led, and so on. MyCERN. And on the right, all the task teams, or not all, but 5 of the 15 task teams of the Regulatory Ethics Working Group, and crossing over as much as possible to prepare the policy instruments needed by Canadian researchers. We have a great reputation. We are still, and I think even more so lately, going to be considered international citizens and leaders in the field. And hopefully this project will allow sufficient support to take that work forward. But to conclude, there's a quote, I had it in Latin on here, but I took it off. There's a quote about standing on the shoulders of giants. And you can see there's one little discovery, innovative scientist there. But if you look closer, these are actually all collaborating individuals. So there is no giant. There may be from time to time, Isaac Newton, et cetera, or Michael. But it's actually the giant are the researchers, communities, and working together then in an international collaborative way to, one, activate the right of all citizens to benefit from scientific progress, and two, make sure that all scientists are recognized for their work. Thank you. And that's my time.